Hi everyone, today I shall be taking you through a new phase of creating a new face. My topic of video presentation is on the advent of osseointegrated implants in oculoplasty. This is a new addition to the armamentarium of orbital processes that we have. The conventional orbital processes are of two types, one spectacle mounted and two adhesive retention, but they have their own disadvantages. These pitfalls led to the idea of osseointegration of orbital processes. Now, what is osseointegration? Way back in 1960s, a Swedish physician and researcher, Professor Bainmark, discovered that when titanium rods are passed into a rabbit's tibia, it became one with the bone and inseparable once the healing occurred. This integration of bone with the titanium implant is called osseointegration. The biological process behind osseointegration is a combination of bone regeneration and remodeling, very similar to the healing process observed in fractures. Application of osseointegration has further expanded outside the oral cavity to include the craniofacial area like BAHA or bone adhered hearing aid and implant retained ear processes. Here is a simple animated video showing the surgical procedure of osseointegration. 3 to 4 titanium implants go into stable bone where osteotomy is already made. These implants have a magnetic property. The reverse pole of these implants is incorporated into the processes. So, the processes snugly clicks on and clicks off. The process of osseointegration is a 3-step process. First, it's important to choose the correct size of implant which can sit into the orbital rim. The most commonly chosen are the supralateral and the lateral part of the orbital rim, as there is a good cortical thickness of bone here. A pre-operative CT orbit helps to determine the dimensions and decide on the position of implants. 2 adjacent implants should at least be 1 centimeter away from each other. With this assessment, a template is prepared before the surgery which can act as a guide in determining the skin marking and the exact points where the bone has to be drilled. Templates are of 2 types, 1 tissue supported and 2 bone supported. About 3 to 4 implants are placed on the lateral orbital rim to give a good magnetic grasp for the processes. The patient can be taken up under general anesthesia or local anesthesia if the patient is cooperative. Let us move on to the osseointegrated step 1. With the help of a soft tissue template, the skin marking is made and joined together. Local anesthetic agent is infiltrated subcutaneously. Skin incision is made with a radiofrequency cautery. Progressively, the subcutaneous tissue, orbicularis oculi, and deeper tissues are incised with a radiofrequency cautery in order to reach the periosteum overlying the lateral orbital wall. Now, the periosteum is lifted away from the bone with the help of the sharp end of a periosteal elevator. Bone template is placed on the bone to help orient the direction of drilling. Pilot holes are drilled followed by sequential parallel twist drills in order to widen and deepen the osteotomy hole to the required size. Bone drilling is done perpendicular to the bone as it will affect the trajectory of the implant. Also, copious irrigation is given during drilling to avoid the terminal bone injury that can affect osseointegration process. Now, the implant is inserted into the osteotomy after checking its depth and trajectory. Cover screws are inserted into the implant to avoid soft tissue entrapment and epithelial ingrowth. Periosteum is sutured together with absorbable sutures and the overlying skin is closed with 6-0 vicryl interrupted sutures. The instrument box used in this procedure of step 1 include surgical kit. On opening, it contains pilot drills and sequential drills for various dimensions of osteotomy like 3.4, 3.8, 4.3 and 4.8 mm. There is also a driver and a ratchet. By the end of step 1, the implant is placed inside the osteotomy and cover screws are placed on top of the implant to prevent epithelial ingrowth, and the skin is closed over it. After a wait of roughly 2 months for complete osseointegration, we take a CT scan again to confirm the position of implants with respect to the orbital rim. Now it's time to consider step 2. Let us move on to the procedure of step 2. The cover screws are palpated over the skin and the skin markings are made. Local anesthetic agent is infiltrated subcutaneously. With a number 15 blade, small skin incisions are made to expose the cover screws, and the cover screws are removed gently. Healing abutments are placed inside the implants now in order to form a fistula around the implant. So the basic concept behind step 2 is that the cover screw is removed from the implant and healing abutment is placed in order to form a fistula and is exposed to outside. Step 3 is the fabrication of ocular prosthesis in the ocularis laboratory. This happens after 2 weeks of step 2. The healing abutments are removed and the implant keepers are inserted. These implant keepers have a magnetic property. The reverse pole of the implant keeper is another magnet which sits inside the orbital prosthesis. The impression from the patient is again taken to form a model. The process includes application of a light body material followed by random placement of sticks, application of heavy body material and placement of additional sticks. Over this, a layer of plaster of Paris is applied and left for an hour to set. Now, the model undergoes a series of processes like fabrication, wax trialing, iris centration, carving, texturing, silicone base color matching, extrinsic staining in order to mold into the final orbital prosthesis, which can be comfortably clicked onto the patient's facial defect. To summarize, the implant retained orbital prosthesis or osseointegrated prosthesis are safe, durable and reliable. Despite its expanded use in oral maxillofacial, ENT and orthopedic surgery, they are often an overlooked reconstructive option for the orbit. This can be an excellent orbital reconstructive option in carefully selected patients. The complication rate is low, the implants are well tolerated, and both the implants and prostheses require minimum long-term maintenance after the early post-operative period. This boosts the patient's self-confidence and increases the quality of life of our patients. As oculoplastic surgeons, it is imperative that we handle the disease and its iatrogenic repercussions. I thank you all for your patient listening.